Hello, everybody. My name is Dr. Al Heuer. I am a professor at Rutgers School of Health Professions. I'm co-owner of A&T Lectures with Terry Shenfield. For this session, we're going to try to take some of the theory and some of the concepts on pulmonary function testing, take them out of the abstract and the theoretical framework, and actually look at some cases and some practical applications. So you can see the actual application of these theories, in actual bedside and a clinical setting. So I put together an ensemble of 3 cases, the first of which involves a 70-year-old man who has a chief complaint of severe dyspnea on exertion. The dyspnea has increased gradually over the past several years. So it really looks like what we're dealing with in this particular instance is more of a chronic, something that is developed over a period of time, rather than something that the person maybe went to bed and they were feeling okay, and then in the middle of the night something happened abruptly. So it's not the more acute, something that is really building over a period of time. He's had severe kyphoscoliosis from his teenage years. He denies a history of cough, sputum production, smoking, working in a polluted environment, or respiratory disease. So that's significant. That's significant. So it's chronic, but at the same time, what's superimposed on top of that is some of the more common, if you will, causes or more common manifestations don't seem to be present. Physical examination reveals tachypnea, tachycardia, jugular venous distension, ankle edema, and kyphoscoliosis. So this is an interesting ensemble of findings. Okay, so the individual has kyphoscoliosis. Okay, he is in fact short of breath. His heart rate is above normal, but he also has these peculiar findings involving jugular venous distension and ankle edema. So these would be findings that would be more typical of something like right heart failure. So let's read on and see what we can discern. So again, some personal data to review. He's 70 years old. He's 66 inches tall. He's about ideal body weight of about 155 pounds. So he really seems like he's in a kind of a normal or ideal body weight range. And we said this is a male that we're dealing with. So they do some spirometry on him, okay, and they do the forced vital capacity. And in fact, the forced vital capacity for him predicted is just under 4 liters at 3.78. But the observed is well beneath that. The observed is 1.46 liters for a percent predicted of 39. The FEV1, the predicted is 2.57. The observed is 1.40 for a percent predicted at 54%. The FEV1 to forced vital capacity. And to review, the FEV1 to forced vital capacity is the percentage of the forced vital capacity that can be blown out in the first second of the maneuver, of the forced vital capacity maneuver. The normal or predicted, depending upon which book you read, what we've listed here is 75. In some cases, you may actually see up to like 78%. I've even seen occasionally 80%. But in that range of about 75 to 78% of the forced vital capacity should be able to be blown out in the first second. In this particular instance, it's 96%. It's 96%. And the interesting thing there is this, okay, that again, forced vital capacity is significantly reduced, okay? The FEV1 to forced vital capacity is actually increased. It's increased. And again, we'll talk a little bit about that, but that may be owing to the fact that that chest wall is restricted, is restrictive. It wants to return back to that resting state in a more rigorous fashion than, if it were not, if the individual did not have a skeletal wall restrictive disorder such as kyphoscoliosis. The FEF 2575 is predicted is 2.46. The actual is just over 2 liters. for 82% predicted. Okay, so one of the measurements of a small airway, small airway flows or obstruction does not seem to be really present. While it is reduced, it's still in that 80 to 120% range, which really is deemed, for most of our patients, is deemed to be in that normal range. So let's look at some lung volumes. Let's remember again that, when you're looking at patients that have restrictive disorders, that they tend to have normal, this is a gross simplification, but they tend to have normal or supernormal or higher flows, but their volumes tend to be lower. Okay, the volumes tend to be lower. And again, just to kind of make the comparison, and we'll do that through these case studies, obstructive disease, you kind of have the opposite. With obstructive diseases, you actually have lower flows, but you tend to have higher volumes, owing mainly to the fact that it's obstructive and some of those patients can actually air trap. So again, we're going back to this restrictive patient that we're looking at. The vital capacity, the predicted is 3.78. The observed is about 47% at 1.79. So it's less than half of what it really should be. The functional residual capacity predicted is 2.42. The observed is 2.01 for an 83% predicted. The residual volume, 1.75. The observed is 1.86 for 106% predicted. The total lung capacity, 5.78. The observed is 3.65 for a 63.2% predicted. And then the RV, residual volume to total lung capacity. Okay, really looking at residual volume again, what is normally not exhalable, if you will. Okay, predicted was 30%. The observed was 51%. Saying that the residual volume is accounting for a disproportionately high percentage of the total lung capacity. Okay, so overall, looking at the picture here, you can pretty much see, with the exception of the functional residual capacity, okay, you're looking at, certainly a vital capacity and a total lung capacity that are significantly reduced. And again, that relationship between residual volume and total lung capacity is also, it's greater than what it would be, but it really speaks to the fact that, unfortunately, when you're looking at above residual volume, okay, that the residual volume is accounting for a disproportionately larger percentage of the total lung volume. So let's try to put all the pieces together and see what this means. Spirometry reveals a small forced vital capacity and FEV1 with a normal FEV1 to forced vital capacity ratio. And again, also the FEF 25/75 is also in the normal range. This suggests that the small FEV1 is caused by restrictive lung disease in small lung volumes rather than an obstructive impairment with low flows. So this is kind of the devil's in the details here. The lung volume studies demonstrate that a small vital capacity and total lung capacity, these findings are consistent with a restrictive lung disease, particularly one that's a skeletal wall restrictive lung disease. The lung function studies are typical for a patient with kyphoscoliosis. Kyphoscoliosis, particularly if it's of a severe, or if you will, severe nature, causes a reduction in the size of the thoracic cage. So actually the lungs are not able to fully expand because that rib cage itself is actually, it's smaller, it's compressed, particularly compressed on one side, and can severely compromise lung expansion and eventually can result in pulmonary hypertension, so cor pulmonale. Okay, so even things like not just compressing the lungs, compressing the heart, compressing the great vessels, which can contribute to, if you will, right-sided heart failure, resulting in the manifestations, which we talked about earlier, that initially seemed a bit unusual, the elevated jugular venous distension and the pedal edema. So just for a moment to talk about the jugular venous distension, that would kind of be reflection, think about what happens. So you have right heart failure, you have when I say backup of the venous plumbing system, okay, I'm crudely calling it a plumbing system, that if you've got a backup where that the right ventricle, the force with which it must beat is greater than it would otherwise be. And if you think back, when you took anatomy and physiology, that the, if you will, the cross-sectional wall of the right ventricle was thinner than the left ventricle, okay, in a normal individual, in a normal, if you will, sheep or pig, or whichever you actually did when you were, doing your anatomy class. In core pulmonale, however, that right ventricle gets hypertrophic. So it's really the chest, that the wall itself, the cross-sectional wall gets thicker, because in this case, those great vessels are compressed and that right heart has to beat, even harder. Okay. And what can happen there, again, the plumbing system backs up. You have your superior vena cava that again gets engorged. And then when you actually look at your jugular veins getting engorged, secondary to that, etc. When you're talking about, the inferior vena cava, you also have a backup there, but the backup has manifested itself in the gravity dependent regions, including most notably the ankle. So you get pedal edema. Let's turn our sights to a second case study. This one involves a 38-year-old man who complains of long-standing dyspnea on exertion. So again, another, if you will, chronically building up, although he's much younger. So it's chronic, but he's 38 years old, not 70 years old like the other patient we just looked at. His dyspnea has increased over the past year and now occurs with minimal exertion. He denies cough, chest pain, or sputum production. He has a 40-pack year smoking history, which is not insignificant. And it's a double negative. It's significant, 40-pack years. It's not 100, it's not 80, but it's still somewhat significant. There is no history of exposure to environmental pollutants. Physical exam shows large AP diameter, or anterior posterior chest diameter, with diminished breath sounds bilateral. So really suggestive of like air trapping, and sort of on a chronic basis. So 38 years old, 76 inches, 188 pounds, and the gender is male. Okay. So you're really saying this is kind of a gradual thing going on here, but he's a young man and something's missing from the equation. I'm just kind of scratching my head here thinking that. So looking at some spirometry, forced vital capacity predicted is about 6 liters. The actual is about 5. So he's at 79, marginally low. You say borderline low at 79% predicted. The FEV1 predicted was 4.52. The actual was significantly reduced. So about a third of what it should be at 1.53, or 34% predicted. And then the FEV1 to forced vital capacity percentage, it again predicted is 75%. The observed is 28%. So that alone, so it's just to focus for a moment on FEV1 forced vital capacity. I know I described, in the previous case what it is. The amount, the actual percentage of the total vital capacity that can be exhaled in the first second of that maneuver. Okay, it is a very good indicator of obstructive airway. It is less effort dependent than things like peak flow. So we still use peak flow. Peak flow can be very valuable, but peak flow can be, it's effort dependent. If the patient is instructed poorly or just has poor effort, it's going to be unduly understated. With FEV1 to forced vital capacity, it's harder to mess it up. Typically you get a more accurate finding. And in this particular case, the scary part is it's significantly reduced. So you're really saying we probably have some sort of an obstructive disorder going on. And by the way, we're talking about this case study, but if this was a credentialing exam, whatever, they're thinking this is real. They're not doing the poor effort thing. So there's something going on from an obstructive perspective here. So let's take a deeper dive. So the interpretation and the discussion, spirometry reveals a markedly low FEV1 and FEV1 to forced vital capacity, indicating a severely obstructed patient. So he's got an obstructive ventilatory impairment. The discussion really stems from the fact that the forced vital capacity measurement, pre-bronchodilator and post-bronchodilator, and static lung volumes as well as diffusing capacity, DLCO, measurements would help further evaluate this patient's status. There should be a high index of suspicion for alpha-1 antitrypsin deficiency in this patient, given the severity of his disease at such a young age. So let me just try to close the loop on this case. The reason why we're really starting to think about the alpha-1 antitrypsin is this. We probably don't have enough information to make as big a leap as this, because could this potentially be, a patient that's asthmatic? Potentially, okay? The pre versus post bronchodilator will be really critical in helping make that determination. So with the pre versus post bronchodilator, you're looking for an improvement that approximates about 15 or more percent. Some of the books say 12%, some of the books go as high as the 20% change. But if you figure crudely between 12 and 15%, that would be suggestive. So if this patient, in further testing, if they had the pre versus post, and that the, if you will, the forced vital capacity and forced vital capacity FEV1 measurement or relationship improved by more than 12 to 15%, it would really be saying maybe we're looking at something that's closer to asthma here. Okay. Static lung volumes would just give you a more accurate way of saying how much air trapping is going on here. And the significance in this case for diffusing capacity of the lung testing, okay, is this. That, again, we're looking at a 38-year-old individual, but if DLCO came back, okay, significantly reduced, that's a finding that you'd see with things like pulmonary fibrosis. It's also a finding that you'd see with emphysema. So it's one of the findings that clearly and demonstrably separates chronic bronchitis from emphysema. So, just to kind of look at the discussion a little bit more, the pre and post bronchodilator would be helpful in ruling in or ruling out asthma. Okay. The DLCO would be helpful in ruling in or ruling out emphysema. So those two tests would particularly complement one another with regard to making a differential diagnosis. Let's look at a third case. 72-year-old woman admitted to the medical service complaining of weakness and shortness of breath. She recently had been diagnosed with asthma, but was previously in good health. Physical examination of the chest revealed markedly diminished breath sounds. There was no wheezing, but crackles were noted at the bases. The admitting chest radiograph or chest x-ray revealed the presence of bibasilar atelectasis, but was otherwise clear. The admitting laboratory work was normal. Her blood gas results indicated that her pH was normal, but the PaCO2 was 54 torr, with a PaO2 of 58 while breathing room air. So let's take a closer look here. So the patient has what's significant in what we read over the past few sentences here. Bibasilar atelectasis, otherwise clear, and the laboratory work was unremarkable. And they're not obviously talking about the arterial blood gas lab work. They're really talking about all the other electrolytes and blood chemistry, CBC, and that sort of thing. So that stuff was unremarkable. The blood gas was remarkable. PaCO2 is 54 and PaO2 is 58. Okay, so in the 50-50 club or 60-60 club. After 3 days of standard therapy for asthma that included inhaled bronchodilators and steroids, respiratory symptoms did not improve. Her PaCO2 had increased to 62, so nominally from 58 to 62. Her chest radiograph was basically unchanged. Her weakness was a little bit better. Pulmonary consultation was requested. The consultant, or if you will, the pulmonary consultation physician requested bedside spirometry. More testing was also ordered, including a sedimentation rate and an anti-acetylcholine receptor antibody test. Okay, and we'll talk a little bit more about that. So kind of a lot of information. The patient's hypercarbic. The patient has moderate hypoxemia. Okay. She was on, standard bronchodilators. She has history of asthma, on standard bronchodilators and steroids, but really didn't seem to respond to those. So you're going to start, again, scratching your head saying, is there more to the story here? So again, 72-year-old female, she's 63.5 inches tall, and she weighs 166 pounds. So she's a little bit overweight. Let's look at the spirometry here. The predicted, so the forced vital capacity predicted was 2.8. The observed was about half that at 1.45. The FEV was 2.13 predicted. The observed was, again, just a little over half that at 1.19. And then we're looking at the measure of obstruction. Again, she's got a history of asthma. FEV1, the forced vital capacity, is basically normal. 75% predicted, 82% actual. So you're saying, scratching your head saying, wait a minute, she's got a history of asthma, but one of the key measurements of obstructive disease, FEV1, the forced vital capacity, is saying it doesn't look like that's what's at work here. Or she's still not feeling right, but we treated the asthmatic part of her problem, but not this other problem of hypercarbia. So let's see what we're talking a little bit more about here as far as discussion. Okay. So in some interpretation and discussion is warranted. Results indicate low lung volumes with a normal FEV1 to forced vital capacity. This is strongly suggestive of a restrictive lung disease rather than obstructive disease. Now, again, she has a history of asthma. That's obstructive, but that's not. She doesn't seem like she's in, an asthmatic episode right now. That's not her primary dysfunction, at least right now. Some of the discussions of the restrictive lung disease may be caused by diseases that decrease lung compliance, such as pulmonary fibrosis, so that would stiffen the lung. And then we talked earlier about, kyphoscoliosis that will stiffen the chest wall, okay, restrict the chest wall. They also, however, can be caused by muscular and neuromuscular disorders. Muscular dystrophy, for example, that's a muscular disorder. It's not a neuromuscular, but also there's an abundance of other neuromuscular diseases that can affect it as well. And those include things like Lou Gehrig's disease or amyotrophic lateral sclerosis, ALS, or myasthenia gravis, or even Guillain-Barré. Results in this case confirm a restrictive impairment. Blood testing for antibodies against the neurotransmitter acetylcholine makes the specific diagnosis of myasthenia gravis. So before we go on, let's just reflect for a minute here. So I realize that we probably have some nurses that may be watching this particular video on these case studies that may not have had as much exposure to neuromuscular diseases or the clinical simulations that respiratory therapists are tested on to get their credentials. But one of the common disorders that's looked at is myasthenia gravis, and sometimes it's actually looked at in comparing and contrasting it with Guillain-Barré. Okay, so myasthenia gravis, you basically will have a muscle weakness that typically will start, at the face, the eyes, the face, and kind of work its way out and down. With Guillain-Barré, it tends to work its way, from the extremities towards the core and towards the face and the neck and that sort of thing. Both of them can be very serious. They manifest themselves in different ways. For Guillain-Barré, one of the telltale signs is an elevated serum protein level in the cerebral spinal fluid. For myasthenia gravis, it's actually testing, for the antibodies against the neurotransmitter acetylcholine. Okay, and now let's back to the case. As the myasthenia gravis worsens, respiratory muscles they weaken, and the patient develops what's called hypercapnic respiratory failure, or that was reflected in the blood gas with the PCO2 was in the 50s. This is the reason for the patient's rising, but increased in rising PCO2. Patient's chest X-ray findings, small lung volumes, bibasal atelectasis, are also explained by the weakening respiratory muscles, causing the inability of the patient to take a deep breath. So a lot of things are happening. They're developing atelectasis, but secondary to that they have less, if you will, gas exchange taking place. It's not due to a blood clot, it's really due to atelectasis and underventilation. of the lung. So you have the CO2 that's building up in the arterial blood, and the oxygen that's not traversing in the other direction from the lungs into the arterial blood, causing inability to take a deep breath. So it's problematic. I will say this also. So testing the patient for, again, the antibody is one important thing that you can actually look at. What they also do is with a confirmed or strongly suspected case of myasthenia, is they'll give a medication like Mestinon or Tensilon. Okay, and there are patients who are in a cholinergic crisis. They're in a cholinergic crisis because they're given, Mestinon, et cetera, as a, if you will, to affect the body by, again, reducing the effect of the myasthenia gravis. If the patient worsens by giving a medication like Mestinon or Tensilon, then it's strongly suspected that they're in what's called a cholinergic crisis. So they have, again, the cholinergic side of the autonomic system is flooded. Okay, if the patient improves after being given the Mestinon or Tensilon, then they'll be characterized as being in a myasthenia crisis. So they've improved because they've gotten that particular medication. So let's examine some take-home points. Chest wall restrictive disorders such as kyphoscoliosis tend to reveal themselves in PFTs with lower volumes and normal to higher flows. Neuromuscular disorders such as myasthenia gravis are restrictive disorders which tend to result in lower lung volumes and flows. Think about this for a minute, because not the chest wall that's stiff. It's not the lung itself that's stiff. Okay, it's actually a restrictive disorder that's characterized by weakened muscles. So with those sorts of restrictive disorders, the neuromuscular, you're going to see both that are reduced owing to weakness of the respiratory muscles, inhibiting the ability to inhale normal lung volumes and exhale normal flows. Obstructive disorders such as asthma and COPD tend to be associated with lower flows, especially FEV, forced vital capacity to FEV1, which is less effort dependent than peak flow. Disorders which can cause a lower DLCO or emphysema and pulmonary fibrosis. So really, part of the DLCO is part of the battery of a complete set of pulmonary function tests. It's very helpful in making a differential diagnosis, even a subtle one, between chronic bronchitis and emphysema. Asthma is an obstructive disorder, which tends to be more responsive to bronchodilators. So greater than about a 15%, 12 to 15%, if you will, change pre versus post bronchodilators than chronic ones such as COPD. Here are some references. The Haynes piece, the first piece I've listed here, is an interesting piece because it really talks about debunking some of the myths of pulmonary function testing. One of the ones they talk about is a little bit funny is, we would like to yell at our pulmonary function testing patients, take a deep breath, blow it out, blow it out, blow it out. And we think that, by yelling at them, we're going to make them blow it out more. And what this basically says is there's no correlation between how much you yell at your patients and how well they do. What really matters is instructing them, coaching them and instructing them on proper technique. And then a couple of my textbooks, one of them is a clinical assessment textbook. The other one is Egan's Fundamentals of Respiratory Care. For you non-respiratory therapists, it's still the best-selling and most widely used textbook in respiratory care. Both of these textbooks have chapters that are focused specifically on pulmonary function testing, get at a lot of these issues. So with that, I want to thank you very much for attending today's session. We hope you got something out of it and enjoyed it, and we hope to see you again in the future. Thanks a lot and have a wonderful day. Bye.